So I was requested to talk to you guys about some basics on anesthesia. The basic things we're going to be covering today are going to be looking at some pharmacology for anesthesia, looking at monitoring, looking at some potential complications that you could come upon in pre-op, intra and post-op, and ways to kind of counter those. Just real quickly about me, I have my doctorate in nursing practice, and I'm a CRNA, graduated from UT Health back in 2018. I've been here with USAP practicing at Methodist for a little over a year and a half now. Okay, so let's clarify some definitions for anesthesia. I know y'all had a few questions on definitions. So anesthesia, as defined by the packet that Yuma gave me, is the absence of sensation, reversible alteration in awareness observed on a continuum from an awake conscious state to unconscious. So basically, you're awake and you go to sleep. But there are other types of anesthesia that can be considered, and anesthesia has multiple components. It's consciousness, sedation, as well as analgesia, anxiolysis. So there are multiple ways, multiple continuums to look at it. So local anesthesia is basically where you're giving local anesthetics. It's a reversible blockade of neural impulse conduction, covering pain as well as motor control. You can do it via topical, like benzocaine, infiltration, which is what you normally see, like when you inject it locally in a site and it kind of numbs that site, or regional, which is when you see with spinal or epidural. MAC, or monitored anesthesia care, here's where a lot of people get kind of the gray area and confusion. MAC is anesthesia service that provides sedation and analgesia while preserving spontaneous breathing and airway reflexes. And that's the big thing is they're breathing spontaneously. So when people say we're doing light sedation, moderate sedation, deep sedation, that's MAC. It's all MAC. It's not TIVA. TIVA is not MAC, okay? But the big thing is they're breathing spontaneously. Light is they're fully aware of everything, maybe a little bit of Versed. Moderate, they've got some Versed on board, maybe a little bit of propofol, but they're still responsive to suggestions. Deep is where they're snoozing completely, but still breathing on their own. TIVA is general anesthesia with intravenous agents alone, such as propofol. You have a propofol drip. Why would you use TIVA? Propofol is fantastic for patients who get post-op nausea and vomiting. So that's one reason you could do that. You do spinal procedures where you need to maintain spinal reflexes. Then you would use TIVA, because you wouldn't want to use gas, because gas also affects the spinal impulses as well. So they have dampened spinal reflexes. And general anesthesia, or GA, is anesthesia maintained through use of a combination of IV, inhalational agents, narcotics, neuromuscular blockers, local anesthetics, and other agents. So that's a big, heavy page, but that's kind of the big takeaway. You know the difference between TIVA, MAC, local, general. So different phases of anesthesia application. In pre-op, what are we doing for anesthesia? Anxiolysis, GI prophylaxis, analgesics, antibiotics. Kind of big, heavy words, but basically when we're giving Versed, when we're giving, Pepsid, scopolamine. Sometimes the patients are in pain, you give them fentanyl. Antibiotics might be started. You could also do when they get their local or regionals, like they get their blocks and whatnot. So that's when we're doing, anesthesia in those phases. Intra-op, you have different phases: induction, maintenance, and emergence. Induction is basically, you have your order of operations. You're going to give them some narcotics first, because induction is not, sometimes cannot be, doesn't feel great, when you have a blade stuck in your mouth to have a tube thrown down. Local anesthetics help kind of attenuate the coughing reflex, the sympathetic response, heightened blood pressure when you're putting a tube in. IV anesthetics, you're going to be giving your propofol, your etomidate, your ketamine to kind of get them to snooze down. Inhalational anesthetics kind of keeps them under, or you can give nitrous oxide for induction when you do an inhaled induction. And then your neuromuscular blocker, which kind of helps relax succinylcholine or rocuronium, cisatracurium. Maintenance, you kind of keep them under anesthesia, so you're done putting the tube in, you're done putting the LMA in, and you kind of keep them on an even keel. Use your inhalational anesthetics, opioids for pain, neuromuscular blockers, keep them still, analgesics, Tylenol. Use steroids, decrease some of the swelling, like Decadron. Antibiotics in emergence, we use reversal agents and antiemetics. And post-op, which a lot of you guys see, a lot of times you're giving opioids, various analgesics, again, Tylenol, antiemetics. That's most of the stuff that we give for anesthesia and post-op. So, that was that slide. I gotta click at the same time. We saw that slide? Okay. Pharmacology. All right, so this is very, very heavy. This is like the majority of our slides, and I'll try to be as succinct as possible. Okay, so when we're talking about inhalational agents, y'all hear about inhalational agents all the time. Volatile versus non-volatile anesthetics. What makes them volatile basically means they can explode, or catch fire. But non-volatile anesthetics, nitrous oxide, can't catch on fire, but with support of oxygen can be combustible. Nitrous oxide can be used for induction, like to help bring a patient down. A lot of times they use it for PD, for tonsils, adenoidectomy. And then your volatiles, you have SIVO, DES, isoflurane. Those are the three main ones you use. Halothane and fluorane, those are outdated. They don't use them anymore. Maybe they use them. Halothane in some third world countries is cheap. For inhalational agents, there are some various phases. There's uptake, which is where you're taking it in, and there's elimination. Uptake is determined by various factors. I can list them all for you. Basically, the only ones that we can really, really control are kind of cardiac output. The faster your heart rate, the slower the gas goes on. It's a very convoluted process, but basically, whatever you see in your lungs, whenever you see like end-tidal, you ever heard of end-tidal CO2? Well, they have end-tidal gas levels, and whatever you're basically seeing in your lungs, end-tidal is what's kind of equivalent in the brain. But the faster your heart rate is, the more it cycles out of your lungs. So you're not really keeping it in the lungs as much, and kind of equilibrium with the brain. So you want your heart rate slower, and your partial pressure difference. The higher pressures you have of gas, the more you can throw into the body. That's uptake. How do you eliminate gas out of the body? There's only one way to get gas out of the body: breathe it out. Okay, so that's the only thing that we can really control. And I have it underlined over there is minute ventilation. That's what we can control as anesthesia providers. Everything else, you just gotta let it go. Now here's MAC again. We talked about MAC, which is monitored anesthesia care. Now this is minimal alveolar concentration. What is MAC? Has anyone ever heard of MAC of gas? Like when we say we put them under a MAC of gas? No? So a MAC of gas is basically a statistical representation of 50% of people won't move on sternal incision. Okay, so we have one MAC of gas. It's basically the ideal level of what you want to have for your gas levels. The big thing with these agents is when you not want to use volatile agents, when they have a history of malignant hyperthermia. We'll touch more on that in just a little bit, but you should really know for pre-op, if you have a patient that has malignant hyperthermia or a history of it, and your anesthesia provider should be checking, but tell your anesthesia provider that they have a history of it, because it's a very big deal. Do y'all know where your MH card is? Yeah, y'all answered the questions. Okay, very good. Dang, I had that question later on. Okay, so there are stages of induction when you go under. These stages are really, really important. Why do you have to know these stages? Okay, there's stage, and you're wondering why the picture is on there. I'll tell you guys, I got pictures everywhere. But you're wondering why I have the picture on, and you'll know what I mean. If you've seen Step Brothers, you'll get it, okay? Stage one is basically they're kind of falling asleep, a little bit loss of consciousness and pain of sensation. Stage two is kind of delirium excitement, okay? And they're kind of like coming to, kind of struggling, and then you see phases go down and then in reverse. They go in the same order, but mostly you see these with like inhalational agents. So stage two, delirium excitement, loss of consciousness to onset of automatic rhythmicity of vital signs. So they lose their consciousness and they're kind of hitting that steady level, but they're very excitable is the word. And you'll see what I mean when you come out of anesthesia. And I have some stars on it, I'll come back to that. Stage three, this is where we want to be ideally. There's several planes of anesthesia, suppression and surgical stimulation. In stage four, you don't want to get there. Basically, you've got them way too deep. You start to see like autonomic suppression, like your heart starts getting really off rhythm. You're getting to like 2 MAC of gas, 3 MAC. We never want to get to 2 MAC of gas. Maybe like 1.5 is what I use a lot of time for the oral cases. Stage two, here's a big deal. If you're working in the OR, or if you see someone coming out of stage two, don't touch them. Remember that scene in Step Brothers, like, don't touch my drum set, so like, don't touch the patient in stage two. Let them come out of it, because that's when they're most susceptible to bronchospasm, laryngospasm. So be very, very careful with that stage. Okay, intravenous anesthetic agents. There are a lot of intravenous anesthetic agents. What are they? Barbiturates, phenobarbital, thiopental. We don't really use them as much. The only time we ever use barbiturates is methotrexate. They use them a lot of times for what's the procedure? I can't remember. Dr. Chaco does them all the time.
ECTs?
Thank you. Yeah, very good. Yeah, electroconvulsive therapy. Methotrexate basically lowers the threshold for seizures. Thank you for completing my thoughts. Okay, so ECTs, I went too far. Propofol, what we see most commonly, milk of amnesia. Very quick onset, 15 to 30 seconds, 40 seconds on board. It lasts for about 48 minutes, you know, like it's really perfect for induction. The only bad side to it, there's always a bad side to every drug. No perfect drug. You will have respiratory suppression. You can have cardiac suppression. So a lot of times you have to make sure if you're doing like MAC, we talked about MAC, doing monitored anesthesia care, when you're giving propofol, you're riding that thin line of like, you know, of keeping them from being apneic and not being apneic. It's like, how far can you push this patient before you like throw them under the bus? Plus, like cardiac patients, you gotta be really careful. If they have a cardiac history, you gotta be really careful with them. You gotta really take it easy with it, because if you throw it hard, boom, they can tank on you. Hypotensive, you know, bradycardic. Some big contras that you guys should know about, don't use them less than 3 years old. Pregnant is a relative contra. Breastfeeding, you don't do it with breastfeeding patient ideally. And then egg or albumin is also a relative contraindication. So just be aware of that for y'all. Etomidate, have y'all seen etomidate used before? They use it mostly a lot of times like CVICU or whatnot. If you have a patient that has to be rapid, you know, put under to use etomidate. Why they use etomidate? Because from a cardiovascular standpoint, it's the most stable. It won't really change their cardiac output very much, so it keeps them stable. However, it's got really bad side effects. It's got adrenocortical suppression. So basically their adrenocortical axis, adrenal release and support of themselves in like sympathetic, if they need sympathetic response, they lose that. It's suppressed for sometimes 48 hours, even longer. It can cause convulsions, myoclonus. So is it really good for like ocular procedures? No. And less than 10 years old, yeah. Ketamine, y'all always hear about ketamine. It's originally used for like animals. It's a great sedative, but it's got drawbacks to it. Basically, it dissociates the limbic system from the thalamic system. So basically, a patient can be like sitting there looking at you like, I'm really in pain, but they're really not feeling it. It totally dissociates the pain centers. So it's very, very strange, very cool. Some advantages to it: if you have a patient that's asthmatic, use it with a patient that's asthmatic because it helps bronchodilation with them, but it makes them salivate. So what do you have to give if it makes them salivate? If you do induction, what do you do? Glyco, yeah, very good. Glycopyrrolate. Okay. Contraindications: patients that have like increased intracranial pressure. So a lot of times the cranial cases avoid it. Nystagmus can cause seizures, emergent delirium. Y'all have seen what happens if a patient, and I've told y'all before, my comfort range for ketamine, I don't give it in patients less than 25 years old or over 65. I kind of keep it in that range. That's where they're better suited for it, in my opinion. It can cause hallucinations too. Dexmedetomidine, Precedex, fantastic drug, alpha-2 inhibitor. Great thing about it is it causes sedation, light sedation, doesn't ablate the respiratory response. So it's great for MAC cases, great for coming out of it. Can cause some heavy sedation, especially like in elderly patients. I've seen it happen here before. They wait forever to wake up, so beware of that. For y'all, what's really important is that when you're giving it, you can give it over here on the floor yourselves. You can ask for orders for it, but you have to give a loading dose, 1 mic per kg over 10 minutes, and then a maintenance dose of 0.2 to 0.7 mics per kg per hour. But can cause bradycardia, and because it causes bradycardia, the body reflex hypertension with that one. So be aware of that. Opioids. Okay. Ones you see most commonly: morphine, Dilaudid, fentanyl, sufentanil, remifentanil, and Demerol. Morphine. Problem with morphine that we see a lot of times is that can accumulate in renal patients, mostly renally excreted. Dilaudid is great. It's a morphine derivative. It's 5 times more potent than morphine. Good for moderate to severe pain. Used a lot of times in PCAs. Fentanyl is great, potent, rapid, short duration, but it can cause some CV suppression. Sufentanil is fantastic. It's the most potent. The little goes a long way. It's great for CV cases, very CV stable. A lot doesn't cause that Brady or hypotension. Remy is fantastic for like short, quick bursts, especially like for spinal cases where you're giving TIVA, because inhalational gases also cause some analgesia. They kind of help with the pain a little bit, but propofol does not have any analgesia. So the Remy kind of sits on top of the propofol and helps for that quick, sharp pain. But the problem with Remy, what's the issue with it? As soon as Remy comes off, you literally have no opioid coverage. You have no control. So you have to replace it with some other opioid, fentanyl, Dilaudid on top of that. And Demerol, we don't really use it very often, very weak. Mostly used for like post-op shivering, 12.5 to 25 milligrams. Basic effects of opioids: analgesia, decreased ICP, intracranial pressure, and antitussive, anti-coughing. Side effects: respiratory suppression, apnea, nausea, vomiting, meiosis, truncal rigidity. If you've ever seen that before, it's kind of scary. Basically, like, why can't you intubate a patient? Why can't you get a patient to breathe? Think about the opioids first, because it completely, tenses them up. Brady, hard pooping, hard to pee, crosses the placenta, makes the baby very dopey, for lack of a better word, after birth. Benzos, we see these all the time. You'll see them in pre-op most of the time. Sometimes post-op, the patient's freaking out. Anxiolysis decreases anxiety. Sedation, amnesia, anterograde amnesia. They don't forget what happened before, they forget what happens afterward. It lasts for about an hour or so. Helps for seizures as well. Patient has seizure, benzos are great. Takes about 30 to 60 seconds to happen. Can last for about typically 1 hour, but it's double in the elderly, so really, really sparing in the elderly when you give it. Side effects: decreased ventilation, can have transient apnea, depression, swallowing reflex. So that's mostly midazolam. Then we see Versed. You can see diazepam. We usually use diazepam mostly for like delirium tremens in patients who are coming off alcohol abuse. And lorazepam, you get that picture of Samuel Jackson, you want to get on the Ativan, that's lorazepam is a lot more for patients who are in the hospital, a lot more anxiety, longer lasting. But why don't we use it? It takes forever to start, and it lasts for too long. Once you give it, you can't take it back. Local anesthetics, ones you see mostly are lidocaine, bupivacaine, ropivacaine, cocaine, and benzocaine. They basically block neural impulse conduction, sodium channel conduction into the nerves. Now, they're all weak bases, so what's the problem if you have a patient, let's say you're getting rid of a cyst on the patient's side or something. I'm saying this example because this happened to my daughter. She had a cyst on her side right over here, and they were injecting local, and it didn't do jack. Why, if it's a weak base, why didn't it help with the pain over here local? Anyone have an answer for that? What happens when you have an incitive infection? Does that infection become more basic or more acidic? More acidic. Okay, so when you combine a weak base with an acid, what kind of happens? It kind of neutralizes it, right? So a lot of times these patients have infections in certain sites, and you inject local. You got to be concerned that might not really kind of cover it. You might have to give a lot more. Problem with giving more, you can cause a lot of different types of toxicity. Mostly, like you see it with bupivacaine these days. It can cause like cardiac suppression, methemoglobinemia, and when you inject local, you see mostly a sensory dampening before motor dampening. Does that make sense? You lose sensations before you lose the ability to move. And why do you inject a lot of times? Like a lot of times you see surgeons, or when I inject it with epi, why they inject it with epi? Any ideas why? Constriction. Constriction. Well, basically what it does is what happens with the circulation? It stops the circulation. It kind of vasoconstricts, so it keeps the local in the area instead of spreading systemically. But then you see subsequently like tachycardia, hypertension, with the epi on board. Okay, trying to go through this faster. Neuromuscular blockers, muscle relaxation, depolarizing, you have succinylcholine, and you have rocuronium, and non-depolarizing rocuronium, vecuronium, and cisatracurium. Sux is great for rapid sequence. Why do we do rapid sequence induction? You hear about that all the time. It's basically done if patients have GERD, acid reflux, decreased peristalsis of their guts, basically worried about things coming up and aspirating from there. Or if a patient is just like not stable and we need to get them under fast. That's why we do a rapid. The problem with succinylcholine and what's called depolarizing, it basically causes fasciculations. If you've ever seen it done before, they kind of shake as they're doing it. It's making the muscles contract, but then it freezes the muscles in that place, as opposed to the other neuromuscular blockers, the mechanism of action. A big issue a lot of people see with it, number one, it's associated with malignant hyperthermia. A patient that has the malignant hyperthermia history, family history, no inhalational and no succinylcholine for those patients at all, so beware of that. But also it can really cause a lot of like myalgia and rhabdo. So you have to be very conscious that like young patients, you give defasciculation dose, like give a tiny bit of rocuronium beforehand, 5 milligrams, and then you give your succinylcholine on top of that. It really helps out to reduce that soreness. It can also cause hyperkalemia, so patients that have burn history or kidney history, watch out for that. So just kind of be aware of that. Rocuronium, vecuronium, they're great, but rocuronium is considered one of the most allergenic agents in the OR. So if you see a patient with like, there's a particular like band of splotchiness that goes on their upper chest when you give it to them. You can give a little bit of Benadryl afterwards, they're usually okay, but it's one of the most allergenic agents. It's reversible. Succinylcholine is not reversible, you just gotta wait it out. Roc and Vec and cisatracurium, they're reversible, but Roc and Vec are only reversible, they're the only ones that are reversible by Cigamedex. Cisatracurium, it's reversible, I say mostly, but it can only be reversed by neo and glyco. Cigamedex does not work on it. So if you see it on the chart, you know, and then if you see cisatracurium given, and then you see on the chart Cigamedex, you gotta think to yourself, what are you in store for? Residual neuromuscular blockade. You gotta be very conscious of that, and we'll talk about that in a little bit. Neuromuscular blocker reversal, so you give an agent, hopefully there's a reversal agent for it, there's your UNO reversal card. You give your anticholinesterase, which is neostigmine. Basically what you're doing is you're flooding the whole area with acetylcholine, okay? But what happens with acetylcholine, you're overriding the neuromuscular blocker, which is block the acetylcholine channels. You're flooding it with acetylcholine, but what happens? You stimulate sympathetic response. So what's your sympathetic response? Tell me. The cardiac, right? Blood pressure, dry mouth, you know, fight or flight response, okay? But if you're also stimulating your muscarinic response, so your sympathetic and your parasympathetic response. What happens with parasympathetic? They could pee, they could salivate all over them, they could like frothy. I mean, they could get all this stuff. You can make them somnolent. So you're flooding the acetylcholine receptors with acetylcholine, but you have to give something. You have to give neostigmine with glyco. Why do you glyco? To chill out the parasympathetic response, so you don't have this patient brady out on you, have them salivate all over you and everything. So you give something to flood and then block this area. Does that make sense? Now, Cigamedex is fantastic. New on the market as of a couple of years ago. It's a drug that basically binds rocuronium, vecuronium, aminosteroids. But the problem is you can't give it with renal patients because this complex that you create can clog. You know, like you hear in lupus, how like the complexes bind the like they go into the kidneys and block the kidneys. Same type of thing. And also it cancels out birth control. I know I've talked to a lot of y'all about that when you have patients that are of age. It blocks the birth control, specifically progesterone and estrogen. So make sure you tell your patients about that. Oh, you got Cigamedex, use alternate method for a week. All right, so monitoring. We got through the really, really heavy stuff. Sorry. All right, so pre-op monitoring. Everyone has those patients where you just hear like, okay, that's your nurse ratchet there for you. Basic things that you want to be monitoring in pre-op that you guys should really know about. Your vital signs, of course. I say vital signs, everyone's like, okay, yeah, whatever, I'll monitor vital signs. Why do we really need to know all this kind of stuff? It's really important, especially like blood pressure, SpO2, EKG. Why do we need to know blood pressure? Specifically, what kind of range do you want to keep your blood pressure in a patient that's under general anesthesia? Does anyone know the range of blood pressure you want to keep, ideally? So if you're 120/80, in what range percent do you want to keep their blood pressure? 20%, very good. Okay, why do we do that? Because that's where they normally live. Okay, you don't want them to become hypoperfused. So if you have a patient that lives at 160 over 90, you want to keep them within 20%, okay, which is what, decrease your systolic by 32 is 20% decrease. If they decrease, if they go below that, their body's not used to it. They're perfusing, their brains are perfusing at that level. If you're going below 20%, their brains aren't getting perfusion, you know? I mean, so you can have major issues with that stuff. In SpO2, you want to see how they live normally, if they're breathing oxygen, and are they not breathing with oxygen? Allergies, lab results, you know, big things we're looking for, like potassium, sodium, not so much, H&H, you know, some of the big things you want to watch out for. Blood sugar is a good thing. HCG, make sure if your patient's pregnant or not. We've had patients come in with, surprise, you're pregnant, and they had to cancel their surgery. Had a patient that happened over here and had to cancel their surgery, and they came back a year later for the same surgery. She's like, remember me? So yeah. Make sure you look at your cardiac and echo status, radiology for different stuff. Now airway. Okay, so when we're coming in, you ever hear about Mallampati? What is Mallampati? Everyone's like, why does an anesthesia provider come in and say, open your mouth as wide as you can, stick out your tongue? That's you're assessing Mallampati. Basically, you're looking at the oral airway and how potentially difficult it could be to intubate them. A Mallampati 1 is ideal. You're seeing everything. You're seeing soft palate, hard palate. You're seeing the uvula. You're seeing all the way past there. You have Mallampati 1, 2, 3, and 4. The most deceptive are 2 and 3 because it could be good, it could be bad. 4, you just know you're in trouble. You just can't see jack. So you just get ready for a glide scope. But it's really important when you're seeing people assess it. Look at it for yourself too. Ask them to open their mouths as wide as you can. Know what you're in store for. Especially like in PACU, how difficult is it going to be if they had to be re-intubated? What are you going to need on site? Are you going to need a glide scope? Are you going to need some extra help? You know, so be aware of that. Hyothyroid mental distance, you want to see how far it is basically from the chin all the way to over here. That can anticipate like an anterior airway. If you've ever seen, it's hard to describe, but anterior airways are so frustrating to intubate. It's very, very difficult. And it takes a lot of maneuvering to get it correct. Incisor distance, the distance between their incisors, how hard it is to actually get a blade in there to intubate. And prognath is where they push their jaw forward. That'll actually give you an idea of how much room you've got to work with a jaw thrust, and how much room you have to work with to like get the jaw actually open when you're scissoring the jaw open. And then previous reactions to anesthesia, family history, specifically, you know, malignant hyperthermia. When you ask about that stuff, listen for it. Okay. Intra-op, we're looking at vital signs, again, ventilation, end tidal CO2, we talked about that, tidal volumes, you know, what's your ideal tidal volume for a patient? Does anyone know? How much should they be, how much air should you be shoving in their lungs? 1,000 milliliters? No, 6 to 8 milliliters per kilogram, ideally, okay? You can have arterial lines, central venous pressure, ICP, Swan Gans, BIS. You ever heard of a BIS? Basically, you're reading their thoughts. No, not really, but you're reading their conscious levels. Ideally, BIS that we want in the OR is 40 to 60 is the magical number where they're under really anesthesia. If it's over 60, that means they might be kind of awake feeling it. What's one of the first signs of malignant hyperthermia that we see? Does anyone know? And it can happen, and this is important for you guys to know why, because malignant hyperthermia can happen actually even an hour after you DC your volatile agent. They bring them out here, so you have to know it. So what's one of the first signs? Anyone know? It's rise in temperature. Okay, you can see a rise of a degree in temperature every 5 minutes, and it can happen very, very quickly. They get hot. End tidal CO2 starts to rise. It doesn't rise very rapidly, but it'll happen. All of a sudden, start to kick up. You're like, why do I have 45? Why do I have 55? I've never seen it happen before, but I've had patients that have had a history of it. And we'll go over more of that stuff in detail, but you know, rise in temperature is a very, very big deal. We're running very short on time. Post-op monitoring for you guys, vital signs, respiratory status, what's the difference between residual neuromuscular blockade, laryngospasm, bronchospasm? You know, how do you tell the difference between this kind of stuff? We'll go over that in just a minute. The biggest thing with residual neuromuscular blockade, I'll tell you guys right now, have you ever seen guppy breathing before? Kind of like, and they're trying, you can see the effort, they just can't do it. And there's a difference between stridor and guppy breath. It's like, and it's this shuddering kind of, they're trying to like like, you know, just like, if you're seeing guppies in a tank, it looks just like it. You know, once you see it one time, you'll understand the rest of the time from then on out. That is residual neuromuscular blockade, and you have to know it for you guys, because you have to go down your algorithm. How do you treat it? Level of consciousness, difference between delayed emergence and delirium, pain and nausea. You can always get more, but you can't take it back. So if they're in pain, is it acceptable? If they're nauseous, is it acceptable? Can they hold on to it? Can they last it? Because if you give them more stuff, they're going to be in PACU longer. They're going to be in post-op longer. You also have to watch out for post-op bleeding, case-specific concerns, and post-op urination. Complications and interventions. We're almost there. Okay, malignant hypothermia. I'm touching on this real fast. I know we didn't say it specifically in the email, Ayumi, but I think it's really important for you guys to really know. What is it? Hypermetabolic response to inhalational agents, succinylcholine, and vigorous exercise and heat. A big deal with it is that you have unexplained rise in end-tidal CO2. Rigidity, rhabdo, hyperthermia is one of the first signs. Again, tachycardia, acidosis, hyperkalemia. It can happen anytime during anesthesia. It can happen an hour after you DC your volatile agent. So you guys have to know that. You know where your malignant hyperthermia card is. You guys pointed that way. The big deal is, how do you treat it? Okay, discontinue the agent immediately. Flush out your circuits. Okay, you know, get rid of the gas. Get rid of everything as fast as you can. Hyperventilate. You know, you want to make them into, what happens when you hyperventilate? Make them to an alkalotic state. You know, you don't want them to be acidotic. You want them to be alkalotic, because they're gonna get acidotic. Dantrolene, you guys know what dantrolene is. Okay, always remember this number: 2.5 mg per kg. You guys have to know that, because sometimes it takes a big bowl to mix it all up. So you guys have to be ready to get it ready to throw it in there, because you're throwing it in fast and hard. Cool them. Manage your potassium. You're going to be given probably insulin with glucose. Treat the arrhythmias, ABG. Watch your urine. Urine will turn dark. You know, I mean, you get myoglobin. Try and increase their urine output. Fluids. Call the hotline. You guys know the hotline for us: 1-800-MH-HYPER. You suspect it, just call them right away, and no one will ever argue. Ever call that number. Laryngospasm. Okay, you guys hear about laryngospasms all the time. What is it? Sustained closure of the vocal cords, partial or complete loss of the patient's airway. Who's susceptible to it? Kids are 2 times more susceptible. Young adults are the worst. 18 years old, athletic, strong patients. Yeah, because they close that thing up on you. Patients who have upper respiratory infection. That's why you don't want them having colds beforehand. One of the reasons: asthmatic, tonsillectomy, adenoidectomy. Really susceptible to laryngospasms. Okay, what do you see with a laryngospasm? You hear this stridor as they're trying to pull in. You see a tug right here on the trachea. Increased respiratory, or trying to breathe hard, but there's a specific noise you hear it every single time as they're trying to breathe in. Paradoxical respiratory effort, O2 desat, you know, Brady, and airway obstruction. How do you treat it? What should you have on you at all time post-op? What's the big thing for treatment? Don't tell me jaw thrust. What do you need? Suction. Get your suction. Get whatever is stimulating those vocal cords. Suck it out of there. Blood, spit, whatever. Get it out of there. You know, if it's bile, get it off of there. You also need a mask on it. Why you need a mask? What helps break laryngospasm? Positive pressure. Continuous positive pressure. Ironically, what's the body's natural defense to it? If you have a rise in end-tidal CO2, it breaks end-tidal and it breaks a laryngospasm. Do you want to have them have their end-tidal CO2 rise up? No. And Larson's maneuver, jaw thrust, as you're pushing it back here. A lot of times people are pulling it from under here. No, there's a specific point right over here. Okay, you crank on that point hard and you push the jaw forward. Oh, it really hurts. And you throw it forward. It's a stimulation for breaking the laryngospasm. Okay, all else fails, you deepen them. You throw in propofol. You throw in succinylcholine. You know, and just get a tube back in there. You know. Okay, benzo overdose. What do you see for benzo overdose? You mostly see with MAC cases, but respiratory depression, apnea, decreased systolic blood pressure, decreased level of consciousness. What's the agent? Flumazenil, romazicon. How much do you give? You guys should know this dose by heart. 0.2 mg of IV. Takes about 2 minutes. It lasts for about 60 seconds. What's the problem if you have an elderly patient? Is what's gonna last longer? The flumazenil or the benzo? Benzo might last longer, okay? So for these cases, you have to make sure you monitor them continuously, especially for an hour. They could have relapse afterwards. You can also give repeated doses, 0.1 mgs every 60 seconds. Now you say you're supposed to only give a total of 1 mg, but think about it, if you start giving more and more and they're not responding, up to 5 mgs, if they're not responding up to 5 mgs of flumazenil, something else is happening. So go down your algorithms, think about it. Opioid overdose, kind of similar to benzo, respiratory depression, apnea, truncal rigidity, intractable meiosis, you see those pinpoint eyes, decreased cardiac output, decreased level of consciousness, unresponsive, nausea, vomiting, constipation, urinary retention. What do you give? Narcan, okay? Now here's the problem with Narcan. The textbook dose is 0.4. What happens if you give 0.4 to a post-op patient? They get no opioid coverage, and they're screaming, and now you got a patient screaming in pain, okay? So it's better to give 0.04, a tenth of the dose, every 3 minutes. Get a little bit on board, kind of see if that's what's happening. Decrease that level of opioid, or decrease the binding at the mu sites over there. Again, but the problem now, I didn't mention before in benzos, what happens when you reverse benzo? What are they at risk for? Seizures, okay? And then when you reverse opioids, risk for pain, screaming, lots of screaming. You don't want screaming. All right, residual hypnotic sedatives. I know you may ask me, it's like, what is the cure? You give him too much propofol, give him too much ketamine, give him too much Precedex. Best advice, tincture of time, grasshopper. Just gotta wait it out, okay? But a big thing is, a lot of people say, oh, he's had too much propofol, he's had too much ketamine. Is it that? Is it really that? It could be residual neuromuscular blockade, guppy breathing, benzo opioid, okay? Think about those things. Other agents, Phenergan, sedation, Benadryl, blood sugar could be low, check your blood sugar, Stroke, MI, it's possible, So think about all these other things, if you're thinking, oh, it's the propofol, it's the ketamine, go down your algorithm, look at the physiological signs, support them, respiratory, if they need masking, CV support, stimulation, maybe don't stimulate them. You really want to stimulate a ketamine patient that much? Not really. What else? Dialysis, CT, MRI, rule out what's going on, get rid of whatever's in their system, call for help. Those are the big things. All right, do you guys have any questions? I went a little bit over my time, probably double my time, but what questions do you have? What concerns do you have for anesthesia? What haven't I answered for you? No?
I have a question.
Yes.
So I've seen nurses in my 5 years I've been doing PACU.
Yes.
Their patients come out and they're immediately shaking them. Hey, wake up. It's time to wake up. Your surgery's over. So what's your suggestion in this? I know you talked about the stages and when not to try to do that with them.
Okay.
Because I'm kind of once I see them starting to wake up, maybe I'll arouse them.
Right. So that's a good question. So a lot of times what you want to clarify, so when you have patients coming out, they're either coming out fully awake or they're coming out deep, okay? When you're taking a patient out deep out of anesthesia, you're ideally extubating them in stage 3 that we talked about before.
Mm-hmm.
You bring them out here and they're breathing off gas. They could be in stage 2. So before you start saying, wake up, wake up, wake up, and they could be going through stage 2, young patient laryngospasm and whatnot.
Mm-hmm.
A real quick, simple test to see if they're in stage 2. Do you know how to tell?
Eyes.
Eyes, yeah, very good. Just flip up the eyelids real fast. If that's enough stimulation to wake them up, fine, great. But if you see disconjugate gaze like that, just don't mess with them. Just leave them alone. Let them wake up. When they start to come to, then you start talking to them. But the last thing you really want to do, like you said before, just hitting them, pounding them on their chest, saying, wake up. Now, if they're desatting, turn your oxygen up, put a mask on their face, something like that, that's when you start, intervening, if they start desatting. If their saturations are fine, leave them for a little while. Now, if it goes on too long, go down the algorithm of is it too much sedation? Is it too much benzo? Is it too much opioids and whatnot? If they're going on an hour, they're not waking up after volatile, that's quite a while, you know. But I would say leave them alone. Let them go through the stages, you know. Better to not poke the bear, you know. Laryngospasms are very scary. You break them, you know, but when you've had a true laryngospasm, you had a patient almost die on you, or a bronchospasm, which is actually worse, there's really nothing quite as scary, or, you know, and makes you want to change your pants afterwards, you know, when that happens. So, yeah. Any other questions by anesthesia? Things I need to clarify? Now's the time. I'm happy to answer any questions, concerns, confusions. No? Yeah, processing it. Yeah, it's a lot of information. It's me putting in 3+ years of info, and I'm still learning. I love anesthesia. I'm still learning about it. There's so much more to learn. We don't even know how propofol really works. We really don't. Like it affects GABA. Okay, it affects your reticular activation system. They really have no idea how it really works. You know, it's magic. So, okay. Any further questions? Okay. Thanks, guys.